We certainly look forward to the next one, hoping that it will even be a greater success than this one. We want to thank you all for the input and the support that you have provided in making this a possibility. And what we plan to do is to use the first hour to allow our colleague Tobias to present, to give us a presentation. Thereafter, we shall spend the rest of the hours, the next hour, navigating the HoliCare Academy platform and supporting all of you in how to use it so that we can have active engagement throughout the next 3 years of this project. And then we also, of course, hope that this will continue to live on long after the project. I don't want to speak for too long. The assumption is that as a consortium, we all know each other quite well, and that we can continue to exchange information as well as get to know each other better, especially using some of the features in the platform that we shall navigate shortly. But without further ado, we would like to give the platform to Tobias from Karolinska Institutet, who will be talking about global child health, and he will introduce us to the lower respiratory infections from that perspective. Tobias, the floor is yours.
Thank you so much, and thanks for organizing this. And I'm really glad to be here. And I also think this is a nice way of sharing knowledge and experiences between us in the HoliCare team. And I got asked just to give a 15-minute introduction on global child health to put all of us more on the same level in basic knowledge about global child health. What is it? What are the key concepts, and what is good for all of us to know? And I will touch briefly about the respiratory illnesses because that's the focus of the HoliCare project, but not much. And later on, colleagues both from Uganda and other countries will then present more in depth about the clinical part of it and the diagnostic part of it. So this is really taking the broad level and the upper level and looking at it. So that's the overall thinking. And please, we're not around the same table, but we're around the same computers. So if you have comments, questions, raise your hand, write in the chat so we get an interactive session, although we're still sitting here looking at our screens. And I'm glad to see the 4 of you at Spider sitting in an office together. Is that fine for everybody? And I got asked to do it 15. This will maybe take 15, 20 minutes, and then we have time for questions, comments, and discussions.
Perfect from our end, Tobias.
Great. And then now I hope that everybody can see my screen. So again, this is a brief introduction. This is something I teach about sometimes during a day, sometimes during a week, and sometimes during a semester. Now I will give it in 20 minutes. So this is a crash course for all of you. But I believe in the HoliCare team, we can do that. But first, I would like to start with, when we discuss children, how do we define what is a child? And if everybody can just take 15 seconds and you around the table can discuss that, then if you have someone you would like to say good morning to over the chat, you can start chatting to someone individually and just, what is a child for you and how do we define that? I think that's an important starting point. Let's take 20 seconds and think.
Should we mute it? I think it's okay if we're not muted. I would think that anybody who cannot manage life on their own is a child. But the definition, of course, varies. Like, is a child also a youth?
No.
It
Yeah.
should be 16, I think, to be youth.
Yeah. Okay, so anybody who cannot manage life.
But that could be someone who's disabled as well. Is that a child?
It's great. 20 seconds have passed and I've heard some discussions around the table. So that's excellent. Let's take someone first online, not around the table. Someone, what's your definition? What's a child? Anyone, just what would you like to?
Well, in the UK anyway, I thought it was just defined as anyone under 18.
Yep. That's the formal definition that we'll come to. Thanks a lot. And we can take that from the beginning. That's the United Nations, in the United Nations Convention on the Rights of the Child. every
Ah.
human being below the age of 18 years old, unless under the law applicable to the child, majority is attained earlier. A couple of countries have had 15 because you are not allowed to have child soldiers. So countries who would like to have soldiers age 15 and older, but now almost all countries in the world, they have 18, the law, but that's the legal one. And then I heard some discussions around the table that it's not only the legal, but that's the correct and important part of it. What did you discuss around the table?
We raised issues around function variabilities as well. Is somebody who is completely dependent on, I don't know, additional support, considered a child even if they're 37 years old? We talked about anybody below the age of 16, I think, where we wondered, could we look at somebody who was 15, 16 and able to manage life on their own as a child? So it was an ongoing, 20 seconds was a bit short.
Thanks for sharing that. And I think that's also very good comments, because when I work in my emergency department, if I have a child 16 years old and I tell him or her that she or he is a child, that's not a good starting point. And I think that's very important. And we know, so in these 18 years, we have both children and adolescents. And then we also know that the frontal lobe of the brain that will be used to control us and how we can manage to plan, that's not fully developed until maybe between 23 and 25 years. And especially in young males, that's very time consuming to get developed, as we have seen. If someone in a gang of 10 kids say, oh, that's a good idea to jump from this cliff, and everybody knows that that's not a good idea. If the kids and the friends tell that, most kids, especially young males, will jump. So that's also interesting to see how you define that. And then you discussed around the table also this about dependency, that children are dependent on their caretakers, most often the parents, but it can be someone else as well. And that's also an important aspect of a child. And then we see some in the chat. Great, still needs parents' care. Thanks a lot, Jean-Claude, very important. And then also now from Konstantinos here, age define, what is the difference to adolescents? Yeah, that's also, or infants. Infants normally, that's below the age of 1, if we look at it from an epidemiological perspective. And then adolescents, it's different. Sometimes it's from 13 to 19, sometimes from 15 to 24, adolescents and young adults. But we have different definitions. When we work on it, it's 18. And when we look at it from a mortality perspective, we often use under 5 mortality, because once you reach the age of 5, the risk of dying is becoming much lower. So different parts, and I will present some of the concepts, but it's just important to think about it when we say a child. But the legal one until the age of 18, and then there are many different definitions. Thanks a lot. Now I thought of just waking up. 5 quick questions. So if everybody can take up their phones, we have 5 quick questions on Kahoot, just to see where we are with the basic understanding in the HoliCare team. I hope you can see my screen now. You have the QR code or the game pin. Please log in, and we'll let everybody have a minute to log in. Alexandra, you were the first. Great, congratulations. And I even have a small prize for you, the winner.
The avatars are fascinating, Tobias.
I can see Muna, Miriam, Aman, Alexandra, Julia, Mido, and Ahmad. There are some more, I believe. Please, have a go. Don't need, I know when you're with research colleagues, everybody's just feeling stressed, but this is not a test. You will not be scored. This is just to see what you know and get to start thinking a Friday morning.
I'm a burger.
Well, I'm a baby.
Have you all managed to log on? Everybody who would like to join us, then we start. 5 quick questions. Great to see now also that you joined Kostas. Great, let's start. And if you're, oh, great, M and Olivia, and wonderful. So the first question now is, everybody's curious. How many children die globally every year before their 5th birthday? So this is what we call the under 5 mortality. How many children die every year before the 5th birthday, from they're born alive until they turn 5? Is it 1 million, 3 million, 5 million, or 10 million children on a yearly basis? You have another 10 seconds to go. You're quick. Almost all of you have answered. That's great. Lovely. So most of you got it right. This year, or last year actually, it was approximately 5 million children who died before their 5th birthday. And then we can discuss later on if that's a lot. It is a lot, but compared to what and what it was. But that's a good basic number that we should all know working in diagnostics or child health or whatever. We can always compare it. Let's move. Alexandra, Aman, and M. You were quick and right. Next question. If we know how many children die, then we need to know how many children are born every year in the world. How many children are born every year in the world? Are there 30 million, 80 million, 140 million, or 400 million children born in the world every year? Seconds to go. Someone else to answer. Don't Google, think. Oh, here, that was a scattered answer. But the right answer, this is also, many of my colleagues working in pediatrics, working in global child health, are very good at numbers. They don't know this. You need both the numerator and the denominator, I believe. Otherwise, you cannot judge what's important and what's a lot. Approximately 140 million children are born in the world every year. Good number also to have in the back of the mind. Good. Let's continue. Let's see. Now, Alexandra, Ahmad, and Aman still in top. We continue. Then we have an important concept that is the under 5 mortality rate. And the under 5 mortality rate is the number of children dying before the 5th birthday out of 1,000 children born alive. 1,000 children born alive, how many of these children will die before they turn 5? And the question here in Sweden, is it 3, 15, 50, or 100? Another good number to know. Yeah. Now you're back to the 70s, all of you, when this number was 15. We're actually down to 3. The under 5 mortality in Sweden, it's very low. Most children born alive survive the 5th birthday and will be adults in Sweden. Still, this is not 0. There are still children dying and not feeling well in Sweden, but globally, this is a low number, and a number always good to know when you travel to country. Compare that to Sweden and other country. Any country we work with in HoliCare? Now, Ahmad, you're in top, and Alexandra, the 2 ones with the right answers. Let's move to the 4th question. 2 more. Now we move from Sweden to Uganda, another country we work on in HoliCare. What's the under 5 mortality rate there? Is it 3, 15, 50, or 100? And these are just estimations. The actual number is not any one of these, but close to them. And here you see the nice map of Uganda. 15, 50, or 100, under 5 mortality in Uganda. You're better in knowing the right numbers in Uganda than in Sweden. That's good because we work in Uganda and not in Sweden. So it's close to 50, and that's much higher in Sweden. But compared, if you move back 25 years, it was well above 100 in Uganda. So the progress and the direction of the numbers is very good in Uganda, but still a long way to go. Final question, moving back. Now we have Ahmad in top, Mariam and Alexandra. One final question. And now we move back to compare the under-5 mortality rate globally between 1990 and 2015, when we had the Millennium Development Goals that has now been the Sustainable Development Goals. What was the reduction and the decline in under-5 mortality on a global level between these 25 years, from 1990 to 2015? 20%, 35, 50, or 65%? Oh. Great. Again, it was actually a reduction by 50%. The Millennium Development Goal was to reduce it by 2/3, so 65%. We did not reach that. Many countries actually reached it, but on a global level, we managed to halve the under-5 mortality rate. At that time, it was 12 million children who died before the 5th birthday. Now it's down to 5, and when we ended this, it was close to 6. So again, is the glass half full or half empty? It depends on what you compare to. Still, all too many children die every year before the 5th birthday, but compared to 25 or 50 years ago, it's much, much better. And I believe we in HoliCare can make a contribution to continued reduction and keeping these numbers going down. So let's have a look. Who will get my prize next time we meet? We have 3. Alexandra will get a prize. Mariam, and number 1. Wow, now we're curious. A round of applause to Ahmad. Congratulations. Well done, Mariam, Alexandra, and Ahmad.
Thanks.
So, as Aman said, Ahmad, now you're ready to graduate. That's good. I like that. Thanks for that. So this is just, you don't, and I often say that to all my students, both when in clinical work and in research, that you don't need to know all the numbers, but a couple of basic numbers in global child death will really facilitate whatever you write and whatever you compare it to. These are my basic numbers that I believe that we will have a test again in a year's time, and then we will all have the right numbers. So now I would like to spend most of the time remaining on what I call the master graph. And this is based on work from the late Hans Rosling, who was a professor in international health at the Karolinska Institutet, who created this tool, Gapminder, that if you haven't been there, you can all go to gapminder.org, which is a great tool to use when you present and you want to visualize health or anything else in the world. And I believe many of you have already seen these, but on the x-axis here, very often it's income, and this is purchasing power parity. So this is adjusted for what you can buy for the income in the different parts of the world. And the more to the right, the higher the income in the country. And then on the y-axis here, we have this child mortality defined as under 5 mortality. And if we look now, we have the basic numbers. We know 5 million children are dying every year in the world. The under 5 mortality rate in the world is approximately 40. What does it look like if we split up the world in the World Bank income categories? High income countries, upper middle income countries, lower middle income countries, and low income countries. In high income countries, for example, we have Sweden here, we have the United States. In Sweden, the under 5 mortality is actually even lower than 3 now, 2.4, I still say 2. In the US, the big green bubble here, the under 5 mortality is 6. Although they're richer than Sweden, due to the very big differences between poor and rich in different parts of the US. Upper middle income countries, there are 3 billion people living. So it's one of the 2 biggest groups in the world. Here, for example, we have China. And in China, we have the under 5 mortality rate of 8 that made huge progress in the last 30 years. They used to be very, very high, now down number is closer to many countries in the high-income countries. We move down to lower middle-income countries. Here we have, for example, India, or less good health, but still much better than the worst countries. And in India, we have an under 5 mortality rate of 33. And just 1 billion still live in low-income countries. Here, mostly you see the blue dots, meaning countries in Africa, and the under 5 mortality still in some countries around 100, and in the Democratic Republic of Congo, where I spent most of last week, close to 100. So big differences in different parts of the world. And an important aspect of this, as well as I showed you the number of children being born every year, very big differences in the babies per woman in these different parts of the world. Low-income countries still close to 5 children per woman. So here we have the big bulk of children being born and being raised now, and the high under 5 mortality. Lower middle-income countries, much lower, 2.7. Upper middle-income countries already below 2, and high-income countries well below 2. So big differences also in here, and important if you want to work on under 5 mortality, also reduce the nativity. So a bit more than 2 maybe in the future, where we have the UN estimations. If we take these 4 different income groups and just look, why do children die? And now we look at the under 5 mortality. And here we have the overall mortality for these 5 million children dying every year. We see all these in the yellow scales. That's neonatal mortality, meaning dying in the first 28 days after birth. And it's much, much higher. The most dangerous moment in life. You know, which is the most dangerous moment in life? Anyone who would like to speak up or write in the chat? Which is the most dangerous moment in life?
Is it the first 24 hours?
Yes, it's even the first minutes.
Okay.
If you have survived birth, then the risk of dying is rapidly going down. And if you have survived the first day, as you said, even better. The first week, better. The first months. And then you have the first year and then the first 5 years. And that's why we have the under 5 mortality. Because traditionally, if you manage to get your children to survive the first 5 years, you could relax. Most probably now it will work out. Historically, close to half of all children being born were dead before they were 5. But here we see preterm birth complications and intrapartum related events, meaning not getting enough oxygen during birth. That's the biggest killers. And then we have lower respiratory infections in children older than 1 month and younger. So close to 15% of the under 5 mortality is lower respiratory tract infections, where we work and where we can do something. And if you also include tuberculosis, another 2.5, even more important. And we have still diarrhea, a big killer, malaria, and here's very important, different parts of the world in sub-Saharan Africa, this is still a big killer, other parts of the world much smaller. Measles, this is horrible, we have a good vaccine, no child should die of this. Injuries growing, especially from the traffic, and then we have many other causes. And if we split this up and use another tool called the global burden of disease, which I also can recommend, and now this is looking at low-income countries, and here we see 3 different colors. The red pinkish, this is infections and neonatal mortality. The blue one, this is non-communicable diseases, meaning mostly congenital and other chronic illnesses also in children. And the green one is the injuries. And now we look, this is in small text, but in low-income countries. Here we see lower respiratory tract infections being up here. I hope you can see the right corner, LRIs, a big part of the under 5 mortality. If we move to lower middle-income countries, still lower respiratory tract infections, a big important part of what we do. If we come to the upper middle-income countries, this is getting smaller, but still quite important. But when we are in high-income countries, smaller part. this is why we have the focus, the HoliCare project in the 3 countries, which are low-income countries in sub-Saharan Africa. This is where we can make the biggest difference in children. And new diagnostics will be useful also in high-income countries, but the impact we can have on the mortality is smaller. Again, just looking at the 5 million children dying every year before the 5th birthday. The blue one here, sub-Saharan Africa, half of that mortality. Southeast Asia, India driving that a lot, also Pakistan, Bangladesh having high mortality. Then East Asia and Pacific, not that the under 5 mortality is that high, but the countries are very populous, and then smaller in the Middle East, Latin America, Europe and Central Asia, and the high-income countries. But if we want to target, we should work in sub-Saharan Africa, and we do that, and also South Asia. I would like to finish with 3+1 4 concepts in global child health that are important to understand, and I've already introduced them. The first one is the under 5 mortality rate, the number of children dying before the 5th birthday out of 1,000 children born alive. Infant mortality, and I also believe, Kostas, you wrote that question, what's the infant? And here, the infant is the number of children below the age of 1 dying before the age of 1 out of 1,000 children born alive. And the neonatal, same, but for the first 28 days. And then in this, we don't calculate the stillbirth, the number of children dying during late pregnancy or during birth. And in many countries, what we would call a child born alive, but with birth asphyxia, not getting enough oxygen. In other countries, they're counted as stillbirths because it's less stigmatizing and it's less, it's more difficult to accuse healthcare personnel for not doing the job they should do if it's perinatal stillbirths. Perinatal mortality is then from 22 weeks during pregnancy to 1 week after birth, to include both stillbirth and early neonatal deaths. In this, we have the HoliCare project, bridging the gap between technological excellence, available infrastructure, capacity and local uptake of technologies to tackle the challenges of diagnostic treatment and prevention of respiratory tract infections. And then I'm so glad to see all these partners and be part of this, to see that we can tackle the most important killer of children under the age of 5. And if we want to do that, we need to work together. It's not enough just to come from a medical perspective, a technical perspective, an IT perspective. We need to get together, work between different countries, and work in partnerships. And if we do that, I believe that this is from the United Nations in New York, and showing again the United Nations Sustainable Development Goals and the 2030 Agenda. We can get the job done if we put the health of the child, as you see, in the middle of the SDGs. With that, I would like to thank everybody for being part and being active. I'm happy to answer questions, comments. Thanks.
You got a virtual applaud from here.
Thanks, Aman.
Thank you.
Do you have any comments, questions, or thoughts? We have discussed this quite a lot before, Aman, how we can work together to tackle this and see the issues. And I believe, again, the collaboration between Karolinska and SciLife and the Royal School of Technology, that's one example about how we can drive the agenda forward and not just talking, but delivering.
Absolutely. Absolutely.
I've got a slightly in reverse question, which is about the problems of overpopulation. Do you think that the psychology of high child mortality causes high rates of childbirth, or is it just poverty?
Traditionally, it's like you say, when you knew that maybe more than half of your children will die, then you needed to have many children, because in many societies the children you had, they were also your pension and the only way you could survive if you got old. So when I lived in Vietnam a couple of years, you needed to get a son because the son would stay with you and the family. And if you didn't have a son, you didn't have a pension, you didn't have a future. So you produced children until you got a son. And then you continue because you were not sure if your son would survive. That has changed now. Everybody knows that most children in Vietnam will survive. And a big part in Vietnam is that on a motorbike, you can only have your wife and 2 kids on one motorbike. So don't get more than 2 kids. Now most families only have 2 kids because 4 people on a motorbike, that's maximum. So I believe you need to get down child mortality if you want to reduce fertility as well. And then it's more complex than just that. And maybe I see now Juliet is online from Uganda and can tell us more about also that. Very important question. Thanks, Simon.
Good morning.
Yeah, please.
Good morning, colleagues. Thank you, Tobias, for the nice presentation, and thanks for the question. Yes, so I agree entirely with your submission, Tobias, because that is what it is in reality here. When you talk to anyone trying to promote family planning and things like that, that is the response you get up to now. Even from educated people, it's surprising. They say, no, what if I give birth to 2 and they all die? What will I do? So really, it's not just poverty, it's that. It's a response to the high mortality rates that people think, okay, I need to have as many children as possible. If 3 die, I remain with 5, But they also still believe in large families, really. They believe in large families, especially in the rural areas, because ironically, they see it as a sign of health, wealth, a sign of wealth. So a person who has very many children is assured of a good future and is seen as wealthy. Yeah, really. So that's it.
To what extent, Tobias, has climate change contributed to some of the numbers that you were sharing with us?
First, I would like to say thanks a lot, Juliet, for adding on that. And I believe you're completely right. And this is so important to continue that discussion and the work. And so far, climate change is not in itself a big killer. These are the traditional illnesses and neonatal mortality. But we see, and the projections, they show that in the future, this will be a big issue. And it's not just the direct effects from heat and issues like that, but it's very much that parts of the world will not be able to live in. And that will create, if you look at the estimations for a big part of the Middle East, in just 10, 20 years, it's not possible to live there. And what will that mean for health and migration? So it's a big coming issue, and it's already an issue that's aggravating problems with morbidity and mortality, but it's not the big killer.
Okay. Do we have any further reflections, questions for Tobias? Yes, Constance.
Yes, great. Thanks very much. So, of course, I would like to say that this interactive way of presentation, Tobias, was really excellent. I enjoyed and I learned a lot, so many thanks. And I think that if the following presentations of the Academy are similar to yours, it would be a great success also to the community. Many thanks for that. I would like to ask, because in our consortium or project, we refer to diagnostics, but I was always having the question, let's say, what is it the driver of so many deaths at the areas that you showed? Is it that the medicines and the drugs do not exist, or they exist and they don't reach the people who need it? And same for the diagnostics. Do they really exist but they don't reach, or they don't exist?
So much for that, Kostas, and I think that's an excellent. I will start, and then I will let in Juliet, who's even more an expert in this, because she wrote her thesis on the private sector, which is an explore. But I think it's very important that it's the whole society and very much about the health system in that in big parts of the world with the high under 5 mortality, children are malnourished. They don't get the vitamins, they don't get the energy they need. They are in a more fragile state once they get ill. Once they get ill, it's complicated often for the families to know how should they do. And if they know, okay, now my child is ill, how can they get that to a healthcare center? And if they get there, they maybe need to pay. They need to pay for the transportation. They need to pay for the cost. And then there is the issue of diagnostics. And that was an issue that some colleagues 20 years ago said that, look, we have so many other issues. We don't need to spend energy on diagnostics for malaria. That will never work. They're too poor. They're too illiterate. This is not well spent. But now we have shown that with rapid diagnostic tests on malaria, we're better at saying what's malaria and what's not malaria. Because as you saw, malaria is still a big killer, but not the biggest one. And a big issue before was that all children with fever in sub-Saharan Africa got treated with antimalarials, and then they died of pneumonia. And this is where I believe we're one part of the solution, but not the only one. So it's important to think about the whole health system. How will this fit into the health system? And then we need to work. And I believe that's also nice with the whole consortium and the discussion we have now, that we also link out to others. How can we support what they do? And then I would like to give the word to Juliet, who worked on the private sector and private pharmacists in their role. Juliet.
Tobias, I think you put it very well. Can you hear me clearly? Because my internet
Yes,
is asking things. Okay.
We can
Yeah,
hear you.
so I agree with everything that you said, really. And so in addition to that, the health care provision is kind of pluralistic with both public facilities and then a big contribution from the private facilities. And the private facilities can either be non-profit or profit. Majority are really profit. Small facilities for profit, and so and also run by people who may not really be well trained, in being able to diagnose and come to a concrete conclusion that this child is suffering from this. And so they need really support in making it very easy to diagnose and conclude that what I am treating is this. And as Tobias said, it gets too expensive if they do not reach a diagnosis quickly, because then they investigate for all sorts of things. And then, the person ends up spending all the money on healthcare, I think that's what I would like to add on what Tobias already said. I hope it makes sense. Yeah.
Thank you so much, Juliet. Thank you so much, Tobias. But maybe it would be helpful to also hear from our colleagues from Ethiopia and also Senegal. Are the realities similar, or might the situation differ slightly? I know AHRI is also here, as well as I saw Sheikh and Miriam were also online. If you want to share some reflections, it would be great to do so before we move into demonstrating the HoliCare platform.
Thank you. This is Adana. Probably before I say a few points, I mean, the situation in Ethiopia, I was wondering probably on the course of this, if the maternal age at first birth has any association. We know there are differences in low income, or I don't know, the low middle or the high income countries where the age at first birth is different. And probably if you see in sub-Saharan Africa, the maternal age at first birth is really very low. And probably, does it have any association with the child mortality? Probably, maybe Tobias, if you just reflect.
Yeah, thanks for raising that issue. And There are numbers there that, for example, if the mother in a low-income country dies during birth, giving birth, the chances of surviving until the age of 5, they're less than 25%. So it's very closely linked to maternal and the child health. And I believe that's something we could spend a whole seminar on as well. So that's a very important part of what you raise. And then again, also what you said, that all countries, there are similarities, but there are also differences. And I believe that if you work in a particular country, it's very important to look at what are the causes of death, what's the most important part, and where should you spend your efforts, so you don't just have one solution to all different countries. There are big differences between different countries. That's also an important. Thanks.
Adane, would you like to add to that? You wanted to share some reflections from.
Yes, yeah, thank you. I mean, as Tobias presents the situation in Uganda, I mean, the number of deaths per 1,000, I think it's more or less similar also in Ethiopia. I mean, when you see in sub-Saharan Africa, although there is a trend of declining in the last few years, but still it's very high. Probably in Ethiopia, I don't know, it was a couple of years, it was about nearly 40 per 1,000. And I don't have the exact figure, and I can see there is a trend of declining, but still, particularly the case of malaria, respiratory disease, and pregnancy complications are few of the key reasons for the high rate of child mortality, particularly under 5. That's what I can say. Thank you.
Thanks for that. And the under 5 mortality in Ethiopia, if I remember it correctly, is very close to Uganda, a bit below 50 per 1,000 children born alive. So, yeah. I
think in 2021, if I'm not mistaken, the report that I saw is about, I think it was 41. And that sounds not, so more or less similar. Yeah, right, Tobias. Yeah, thank you.
Thank you so much, Adane, for the intervention there. We have just 10 minutes left of the hour that we were dedicated to Tobias's presentation. So Sheikh, please do share some reflections from Senegal.
Thank you very much. And I really appreciate Carolina, and I really appreciate the talk given by Tobias. It's very wonderful. So regarding the situation in Senegal, it's look like too many of low-income country, because when I look at quickly the situation, the epidemiological situation in Senegal in 2021, it's the rate of mortality. It's around 39. It's similar to other African countries. And the most problem is, as said by, it's related to malaria in rural area, but also some complications related to pregnancy. And I think, as raised by Costas, maybe if we develop a lot of tools for diagnostic and also improve vaccination, we will have possibility to reduce consistently the rate of mortality among these vulnerable population. Thank you. Thank you very much.
Jake, thanks a lot, Jake. That's also important input. And again, and I believe that's nice that we have Senegal and Uganda and Ethiopia together with similarities and also some differences, but it's great to work together between these countries. And I think we can learn a lot in the consortium.
Very good. I would like to reiterate our big thanks to you, Tobias, for a really interactive and great first webinar, and the presentation, I think, was really engaging on several levels. We at Work Package 7 really appreciate the input that you provided here. May we please ask that you share your slides with us so that we can upload them on the platform for future reference, especially as we continue with the work within the consortium. And We will also upload this recording that we have taken this morning so that further reflections can continue within the HoliCare Academy e-learning platform. I don't know if there's any other reflections, but I just want us to have a round of applause for Tobias and thank him very much for this morning.
Then I would just like to
Thank you very
finish
much.
to say thanks a lot for letting me start off the HoliCare Academy. And if you have time, really go to gapminder.org or Google Global Burden of Disease and find these tools. I think you will all find them useful. And next time you present something, they're really easy to use and good. And just, you know, you will travel to a country, work on diagnostics in India next time, and then you have these basic numbers you can present and put it into the context, and that would make me happy. So they're free to use, and use them, and we share and we get better understanding about the world. Thanks so much.
Thank you so much for that, Tobias. Now, within the HoliCare Academy, we actually have a discussion forum where we would like for you to share some of these resources to us so that we can be able to reference them and engage with the material that you have given us today.